Start. The recording is started.
Okay, thank you, Ashley. So yeah, thanks really for our speaker today, Dr. Wendy Yu. She's an assistant professor in neurology and from the memory unit, and this is in Mass General Hospital, and she's also an instructor at Harvard Medical School. And she will talk today about physical activity as a modifiable risk factor in a preclinical AD disease or Alzheimer disease. So welcome, Wendy, and we're really pleased to have you in today, and it's all yours.
Thank you. Thank you so much for inviting me. Lovely to speak to this group, and stop me anytime. Love to have a discussion. So definitely, if you have a question, or I may not be able to see raise hand, so just feel free to interrupt and ask. So let's see. All right, so this is the outline of my presentation today. I'm going to first talk about how I came to focus on preclinical Alzheimer's disease, and then moving on to modifiable risk factors in preclinical AD, focusing mostly on physical activity, to talk about this recent paper that we published. And in the end, I would just very briefly touch on other systemic vascular risk factors that we are interested in and have studied. I have more backup slides on more details about that if there is time and there is interest. So let me jump in. So how did I come to study preclinical AD? So when I was in medical school, I was in Pittsburgh, and I had the great fortune of working with Dr. William Klunk. Bill is with Dr. Chet Mathis, is the co-developer of Pittsburgh Compound B, which is the very first amyloid PET binding agent, which really transformed the research landscape of AD. And because of that, as a result of that, really transformed now the clinical landscape as well. So in this study, we looked at a cohort of, people with autosomal dominant Alzheimer's disease mutation that Bill had followed longitudinally. And we kind of followed them with both neuroimaging, with amyloid PET scan, and back before we had tau PET. So this was, we kind of scanned these participant with FDG PET scans, MRI, looking at hippocampal volume, and then clinical measurements. And here is showing more of a group level kind of statistics showing how the different imaging and clinical biomarkers change over time. And similar to many other groups have shown, there is this kind of temporal progression where amyloid, abnormal amyloid deposition start early, followed by hypometabolism, and then atrophy and cognitive decline. But what was really unique about the study back in 2014, 2015 now, was that we had pretty a long duration of longitudinal data in 7 of the individuals. So that allowed us to really study the within individual, kind of how the different biomarkers change with respect to each other. So we, out of these 7 people, we saw 3 patterns. First is what we called the active amyloidosis phase in this red box. And these individuals, they are actively accumulating amyloid over time. But their neurodegeneration, metabolism, cognition stay stable. And then we have a couple individuals in these pink boxes, what we term a stable amyloid positive phase. So they already have, accumulated elevated levels of brain amyloid, and that is staying stable. And so is metabolism, atrophy, and cognition. And lastly, we had a couple individuals in what we called this progressive neurodegeneration and cognitive decline phase, where amyloid is high and stable, and they're actively showing decreased metabolism, accelerated atrophy, and cognitive decline. So this really inspired me to focus on the early preclinical period, this period where people are accumulating amyloid over 10 to 20 years because that is, I think, the window where we have the best chance of modifying the disease trajectory. And I really like this perspective paper, how they kind of describe AD in terms of amyloid and the wingman, even though this paper is not exclusively talking about modifiable risk factors. And I certainly, trained with Bill Klunk and Dr. Risa Sperling, so really kind of amyloid center labs. But I do agree with the statement that amyloid appears to be necessary, but not sufficient to cause AD. And I think in clinic, I see, just so much heterogeneity in patients, in our research participants, where people could have, a head full of amyloid and not have a lot of atrophy and not have cognitive impairment, versus you see other individuals that are less resistant and resilient to these pathology. And so really thinking about, what are these wingmen and how can we, this is a famous Jack curves from Dr. Cliff Jack, showing the progression of different components of the amyloid cascade. So really thinking about, what can we do in this early period to kind of delay the downstream, the later, the tau, atrophy, and clinical impairment. So that brings me to modifiable risk factors in ADRD. I think probably everyone's very familiar with the Lancet Commission, kind of evaluating, updating over time, what are the modifiable risk factors for dementia prevention. And so we are going to focus on physical activity today. And then one thing to point out is a lot of these other modifiable risk factor falls under vascular risk, which I hope to touch on later. And then obviously lots of other very important modifiable risk factors like hearing loss that I won't have a chance to talk about today. So physical inactivity, it is very well known as a risk factor for Alzheimer's disease. On the left-hand side is a slightly older paper from 2010. You can see kind of on top, they study worldwide the modifiable risk factors and then in different kind of areas of the world. So worldwide, while physical inactivity is still important, it is not, as important as smoking or low education attainment. But when you look at kind of in US and in Europe, physical inactivity was the most important risk factor. And then on the right-hand side is a more updated or a more recent paper looking at data from 2018 and just from US. And here they showed that midlife obesity is kind of the most important risk factor, and then physical inactivity is second. So still, a major opportunity to intervene. And so there are animal studies that have supported benefit of physical activity on cognitive performance, as well as specifically on Alzheimer's disease pathology. These are not meant to be exhaustive, but just to give kind of some examples of on the top here. In animal studies, physical or activity or exercise has been shown to decrease amyloid burden. And then on the bottom, it has been shown to have an effect on reducing tau pathology. But the evidence from human study, most of, the bulk of the evidence comes from observational studies. And again, these are definitely not exhaustive. There are many, many studies that have been published, but these are, a couple early studies, observational, that showed that higher physical activity is associated with, slower cognitive decline or decreased risk of Alzheimer's disease and dementia and aging. However, there are important gaps that remain. Most of the observational studies, they relied on physical report of physical activity. And this is prone to, recall bias and misremembering, especially in populations that have or are at risk for cognitive decline. And importantly, a lot of these studies were done in the pre-biomarker era. So most of them looked at the clinical syndrome of AD. So very few of them directly examined core AD biomarkers like amyloid and tau, and even fewer have done so longitudinally. So this is where, the Harvard Aging Brain Study has been very valuable. So this is a longitudinal cohort study of cognitive aging and preclinical Alzheimer's disease, which is currently in its 15th year. So I've shown there are many more people than what is shown here, but the key leaders of HABs currently, as well as in the upcoming cycle, are featured in the pictures down there. So in HABs, we recruited older adults who were cognitively unimpaired at study entry, and they were 50 to 90 years old. And then overall, we have data on over 300 individuals at this point. And we followed them longitudinally. They get imaging with amyloid PET, tau PET, and MRI every 2 to 3 years. One important point to note is that tau PET wasn't available when the study started 15 years ago. So on average, it was introduced around 2 years from study baseline. And then we, each year, participants come in for our annual cognitive assessment. And one kind of cognitive composite that we use is this preclinical Alzheimer's Cognitive Composite 5, or PAC5. It has, it's a composite made up of MMSE, kind of all these tests that are listed there. And it was developed to be sensitive to the very early cognitive impairment in preclinical AD. So this paper is from 2019 and was led by Dr. Jennifer Rabin and Dr. Jasmir Chadwell from HABS. That was the first one to look at the associations of physical activity on cognition and neurodegeneration. At that time, there were only 180-ish participants, and they were slightly older because in the initial stages, we didn't recruit down to 50 years old. So they were 60 to 90 years old, and at the time, we have about 6 years of follow-up. And in this study, we measured physical activity objectively with a waist-worn pedometer. And we participant wore it for 7 days, and our primary measure of physical activity is their mean step count per day. And so what that study showed was an interaction between physical activity and baseline amyloid burden on longitudinal MRI and cognition. So on top row here is kind of showing the longitudinal PAC5 scores over time. And to illustrate the interaction, I should step back and mention that both amyloid and physical activity were modeled as continuous variables. And then in order to illustrate this interaction, we picked representative levels of physical activity, which is mean plus minus 1 standard deviation. So low physical activity here is represented by, someone who would take around 3,000 steps a day, whereas high physical activity is around like 8,500 steps a day. And same thing with amyloid burden. It was modeled continuously, but we kind of plotted the trajectory for individuals with representative levels of low versus high amyloid burden. And here we can see that, people who have both a low physical activity, so kind of on the left-hand column, and then who had high baseline amyloid burden, kind of illustrated by these red arrows. These are the individuals that showed accelerated cognitive decline over these kind of 6 years, as well as accelerated atrophy measured by total gray matter volume. And one thing that was important to note is that this interaction was independent from effects of higher vascular risk, because as I will mention later, that we have found that vascular risk is also one modifier of preclinical AD progression in our cohort. So kind of building on top of that study, the current study have a few questions that I wanted to answer. First is, would these findings replicate with a much larger sample with longer follow-up time now? And that point is important because some of the observational studies have shown that, once you look at longer follow-up, some of these protective associations of physical activity go away. And then also, midlife is very important. So we wanted to know whether we would see the same relationship now that we're including younger participants down to age 50. And secondly, I had mentioned that in animal studies, people have shown that there is physical activity has an effect on amyloid and tau. Do we see the same relationship in humans? Are the, association with cognitive decline, is it mediated by amyloid, tau, or both? And lastly, what our people and patients really want to know, which we cannot answer directly because this is an observational study, but we wanted to at least kind of start to probe and understand, what levels of physical activity would be associated with cognitive decline. So here is a kind of characteristics of our study cohort. There are 3 columns because, for all participants, these are everybody who had baseline amyloid PET scan and at least 2 cognitive assessments. And then subsets of those participants had longitudinal amyloid PET scan, and then kind of a smaller subset had longitudinal tau PET scan. So this is just to show that kind of overall the subgroup that had longitudinal tau was slightly younger, and because they're slightly younger, they also have slightly lower burden of amyloid and lower kind of percentage of amyloid positivity. But importantly, kind of these 3 samples, they all kind of average close to 6,000 steps a day, which is very good for this, almost average 70-year-old population. And then their baseline cognitive performance was not different. So here are kind of the raw data. I always like to show kind of the raw data to give people a sense of what it looks like and to orient you. So here, there are different outcome measurements, global amyloid PETs, inferior temporal tau PET burden, and then the PAC-5 is the cognitive performance, and then CDR sum of box score is a measure of daily functioning. And each the trajectory, each line represent one individual participant and how their data across time. And this is kind of plotted just for illustration purposes, just so that all the lines are not on top of each other. We plotted it divided by median split, kind of low versus high amyloid burden in the columns, and then low versus high physical activity in the rows. So that's why there are 4 boxes in each. And then one word about why we picked inferior temporal cortex for our tau region of interest. It's been shown in HABs and other studies like ATNI and others of kind of preclinical AD that this is a site of prominent early neocortical tau accumulation. And not only that, that kind of tau accumulation in our ITC is associated with emerging cognitive impairment. So that's why we selected that for our area of interest. And then the only additional point about CDR sum of boxes is we added it to give a measurement for daily functioning, which is, at least that's what mattered most for patients. And also it is increasingly used in primary and secondary outcome in AD clinical trials. So to jumping to the results, we will talk about baseline associations to start. So unsurprisingly, younger individuals have a higher level of baseline physical activity. And then in our sample, men also was more physically active than women at baseline. However, we did not see any associations between baseline physical activity or baseline amyloid PET burden or cognitive performance, adjusting for age and sex. There was, however, a activity by amyloid interaction on initial tau burden. You can see in the graph here. Again, kind of these are representative levels of low versus high amyloid burden. And for individuals with high amyloid burden, if they were also physically inactive at baseline, they start out with a higher tau burden in the inferior temporal cortex. So one very reasonable question is, because this is an observational study and reverse causation is significant concern that we can't fully get past. But one question was that, is the relationship we're seeing just because people who had more amyloid or more tau, there were just, have lower activity at baseline because of subclinical pathology. So we looked at the reverse. And we did not find evidence that there was no relationship between baseline amyloid and baseline tau on baseline physical activity, as you can see here. So there was no interaction and really no relationship individually either. So that was at least kind of comforting. So moving on to the longitudinal results. So I would pause here and kind of orient you to the model. We used a linear mixed effects model. And again, we model physical activity continuously as well as amyloid burden. So the first model we looked at is whether physical activity is related to amyloid accumulation over time. And we adjust it for age, sex, and ApoE4 in this model. And as you can see here, individuals who have low versus high baseline activity, their amyloid burden and accumulation over time was essentially no different. So next, we then looked at the interaction between physical activity and baseline amyloid burden on longitudinal tau, cognition, and function. And to orient you to these figures, to illustrate this three-way interaction between physical activity by amyloid by time, we similarly to what I showed before, kind of picked representative levels of physical activity and also baseline amyloid. and plotted the longitudinal trajectory of tau and cognition and function at those kind of high versus low levels of amyloid and physical activity. So what we have here, so the dashed red line are individuals who have a high amyloid burden at baseline and low physical activity. And you can see in the graphs that these are the individuals who have faster accumulation of tau over time, as well as in a concordant fashion, faster cognitive decline, and then faster increase of CDR sum of boxes score, which it equals a worse functional decline. So we, like I mentioned already, because this is an observational study, we really tried as best we could to do sensitivity analysis to try to kind of understand, maybe there are additional confounding factors that we didn't control for to see whether or how robust our findings are. So I will highlight a few because there was a association with age, which I didn't specifically call out, but older individual had a lower level of physical activity at baseline, which is, again, not surprising. So we, wanted to exclude kind of the older group. So for the sensitivity analysis, we only looked at individuals younger than age 70. And in this subgroup, we no longer saw an association between physical activity and age. And our primary findings of this interaction between activity and amyloid on tau and cognition were unchanged. And then secondly, a lot of healthy habits can travel together. So in the sensitivity analysis, we adjusted for vascular risk, which was measured by a Framingham cardiovascular risk score. And then also season when they wore the pedometer, since people are generally more active in the summer. And then we additionally adjusted for a self-reported physical activity and the depression score. And so the findings were unchanged. One thing to note is this finding was the same if I substituted the Framingham risk score for just systolic blood pressure and BMI, which will come up later as kind of vascular risk factors that we have looked at previously. And then here we also excluded individuals who either developed cognitive impairment within 2 years or dropped out of the study within 2 years. And this was done so that we can exclude individuals who were right on the edge of kind of developing cognitive impairment in case that was driving our results, and that wasn't the case. And lastly, because there was baseline differences in tau, we adjusted in the model kind of the baseline outcome, like tau, cognitive performance, or function, and we did not see any changes in our results. So as best as we could do, it seems like the findings that we observed was robust in these sensitivity analyses. And we, the change in direction in tau and cognition and function were concordant in that, more tau, kind of higher tau and worse cognition and function. But we wanted to formally test it in a mediation analysis to see whether the change in tau is mediating the associations with change in cognition or function. So here it is a moderated mediation analysis, which means that we, ran the mediation models and then additionally tested whether baseline amyloid burden modified this mediation model. So over here in the blue box, this was kind of at low amyloid burden. We did not see any kind of total effect of physical activity on path decline or functional decline, and there was no mediation through tau change. And then on the right-hand side, this is when amyloid or baseline amyloid is high, and we can see that there was a physical activity had a protective association against faster cognitive decline, and then up here, most of that, 84% of that relationship was mediated through tau change. And then down here for CDR sum of boxes increase, the mediation is significant, but there is its own accounting for a lower portion of effect, only 40%. And there was still a significant relationship between physical activity and functional decline that wasn't going through the tau pathway. So, and then the last thing we looked at in the study, as I mentioned, was kind of the relationship between different levels of physical activity and tau and cognition. So we adapted kind of cutoffs from the literature and adjusted it slightly to make sure we had enough kind of participants in each physical activity level. So we defined inactivity as less than or equal to 3,000 steps a day, and then low, moderate, and active based on these cutoffs. And then we, again, looked at the interaction between baseline amyloid and these physical activity levels on kind of change in tau and cognition and function. And what you can see here is that individuals who were the most inactive, if they had high amyloid at baseline, they are the most at risk for faster accumulation of tau and then faster decline of cognition and function. And even kind of a modest increase in, or modestly higher physical activity, just 3,000 to 5,000 steps a day, those individuals had substantially lower kind of tau accumulation that is related to amyloid, as well as slower cognitive and functional decline. And this kind of protective association plateaus across the moderate to most active groups. And so this kind of plateauing relationship has actually been seen in other studies looking at the effects of physical activity on this. Here is mortality, but it has also been seen in studies looking at risk of dementia or AD. I think specifically in our study, I think it suggests that there is a limit to how much physical activity is able to dampen the negative association of having high brain amyloid on tau accumulation and cognitive and functional decline. So limitations. Again, I think this is a observational study, and despite our best attempts to kind of think of confounders, this cannot evaluate causality, and we need randomized clinical trials to do that. Also, we only measured physical activity at baseline, and we do not have information on kind of prior physical activity and no longitudinal physical activity. And while we use pedometer, which is simple and very easy to understand, the downside is it's not able to capture the duration, intensity, or any non-step related physical activity. And lastly, HABS is a highly educated, generally healthy cohort who is predominantly non-Hispanic white. So we do need to kind of think about generalizability and need to replicate these findings in more representative cohorts. And then in terms of, implications of our results, I think this got a lot of interest in the press, partly because it potentially gives a simple and really more approachable approach, especially for sedentary individuals. Our findings suggest that even a modest increase in physical activity is helpful, and really, like, every step counts. So instead of kind of the general 10,000 steps a day that's so popular in lay media, it was encouraging that there, even modest increase of physical activity seems to be associated with slower tau and cognitive decline. Overall, despite it being, because it is an observational study, it really supports testing activity interventions in AD prevention trials. And one, based on our results, it would suggest that, preferentially enrolling sedentary individuals who already have elevated brain amyloid but are still cognitively unimpaired, and using a longer trial duration and considering using tau PET as biomarker endpoint, these strategies may be helpful in detecting a physical activity effect in preclinical AD. And this is a clinical trial that is ongoing, or really, I think, completed. They're on the second phase of the trial. Ignite is this trial is led by Dr. Kirk Erickson, who did a previous landmark exercise clinical trial that showed that 12 months of physical activity was associated with kind of increase in hippocampal volume. So this is a more recent protocol where they are testing a phase 3 randomized clinical trial that's multi-centered, comparing different kind of intensity or duration of physical activity versus light stretching and toning. And kind of relevant to our study, one of their exclusion criteria is that the participants cannot be already doing more than 20 minutes of moderate intensity activity for more than 3 or more days a week, which not quite as sedentary as our participant, but still kind of aiming for that, recruiting individuals who are less active. And I find it really interesting that this is their stated hypothesis when they published the clinical trial protocol. And they hypothesize that the favorable effects of exercise on cognition and brain health will be the greatest for older adults with amyloid burden. So I think our study supports that hypothesis, and I'm really looking forward to seeing the trial results. And they are measuring longitudinal amyloid PET scan as well as plasma p-tau. So it'll be really interesting to see what, intervention does to amyloid accumulation as well as tau pathology. And then in terms of future directions for our study, as I mentioned, one of the limitations is that we only measured with pedometer at baseline. So what we have been doing in HABs in this past cycle is that we have been acquiring longitudinal actigraphy 2 times over the 5 years. And looking forward to the next funding cycle, fingers crossed, there are plans for yearly actigraphy, and this is led by Dr. Stephanie Schultz and Jas Chatwal in our group. And an important aspect is investigating mechanisms. Not everybody can or will exercise, so really trying to understand what is underlying the protective effects, and trying to identify additional intervention targets will be really important. Kind of candidate mechanisms include better cardiopulmonary fitness, which has been shown to kind of dampens this association between amyloid and cognitive decline in unimpaired older individuals. And then greater physical activities has been associated with better cerebral blood flow, so that, I think vascular impairments has been shown to be an early event in Alzheimer's disease development. So that would be a sensible potential mechanism. And then inflammation is an important aspect of Alzheimer's disease, and exercise is associated with reducing both systemic and neuroinflammation. And lastly, kind of the different kind of neurotrophic, angiogenic, and myokine signaling that is upregulated in exercise that has been shown to be kind of potentially modify the early Alzheimer's disease trajectory, like BDNF, VEGF-A, and irisin. And so in the last couple minutes, I just wanted to touch on other modifiable risk factors that we have been studying and that we found in association with tau and cognitive decline and preclinical AD. The study a few years ago looked at systemic vascular risk measured by the Framingham Heart Study cardiovascular risk score, and we found similar interaction with baseline amyloid on tau, which is shown here. So kind of the solid red line is individuals with high amyloid and high vascular risk. So those are the individuals showing the fastest tau accumulation over time. And I'm not showing the effects on cognitive decline on this graph. And then we looked at the different components that make up the Framingham risk score, and we found that it was the systolic blood pressure and BMI that was driving this, this relationship. And then what I'm not showing here that we are looking at currently is physical frailty. So physical inactivity is a major component of physical frailty, but we're also kind of looking more broadly, both using a modified Fried frailty phenotype as well as a deficit accumulation model of physical frailty, and looking at findings relationship with amyloid-related tau and cognitive decline. And I think one major question is, what are the shared versus distinct mechanism? Because I think, like I mentioned earlier, healthy habits, healthy people travel together. So kind of really trying to understand what is shared between these factors and what is distinct to really understand what is driving the relationships. So we are kind of pursuing a focused proteomics with the currently very popular new LISA platform to try to tease that apart. And I think that's all I have today. And, really these studies would not be possible without our very dedicated participants from HAB study that has been with us for 15 years, as well as kind of the whole study team that have been here from the beginning, especially my mentors, Dr. Jas Chatwal and Risa Sperling. Oops. All right, I will stop sharing.
Yeah, thanks so much, really, for a great talk. I think Dr. Salas tried to say something, but
oh yeah, I'm sorry. My video just does not want to turn on. It was a great presentation. Thank you so much. Dr. Sperling, Risa is somebody who I've known a long time. Is just trained in the same residency training program. We had the same people who trained us, and so I had reached out to her to see if we could convince you to give us a talk. So thank you so much for doing that.
Thank you for inviting me.
Really love your work, and I guess what comes to mind now at this point is when we think about having anti-amyloid infusion treatments, what has the better treatment effect? And I suspect it's going to be the lifestyle. It has a broader impact and possibilities, but as you go further and further, and I guess when we learn from this RCT in the University of Pittsburgh, people are going to start asking about the magnitude of the treatment effect, because these drugs that we have, as is often the case in early stages of disease, if you take AIDS or cancer, the first treatments tend to be toxic. And when you just look at the history of medicine, and so if we have something like physical activity, which is pretty safe to recommend, those are the things that I think will be coming up, which is that magnitude of a treatment effect. Just wondered what you thought.
Yeah, I think really looking forward to, in terms of anti-amyloid therapy, I think I tell my patients all the time, and I showed them the clinical trial results, very good, effective in lowering amyloid. And unfortunately, that does not fully translate to the same magnitude of clinical effect. I think the trials are well done, and there's a treatment efficacy, but it is not what we hope our patients would have. I think in terms of, I think a lot of us in the field are, the results from clinical trials are suggesting that, people who have earlier either amyloid burden or tau burden, that they seem to do better with anti-amyloid therapy. So that's why that was the motivation for AHEAD, which is led by Dr. Sperling and Dr. Paul Azen, as well as Lilly has their own preclinical Alzheimer's disease trial. So it'll be really interesting to, find out, if we treat earlier, would we see a bigger impact of anti-amyloid therapy? I certainly hope so. But I think, as you said, there is really no downside to physical activity and these other modifiable lifestyle risk factors. And I think Alzheimer's disease is a complicated disease, as well as people age, there are often multiple things going on. And a lot of what I've been studying, it seems to really have a synergy. It's not two separate kind of vascular versus AD totally separate. They seem to synergize. So the hope is combination therapy that, by targeting both amyloid and these modifiable risk factors, that we would have a, greater benefit. And I think behavioral change is really hard, speaking from personal experience. So it's easier said than done, but I really do think that there really is no downside. Like I tell my patients, like, for example, meditation, like there is really no downside. So, even though, I think we have some evidence with some clinical trials and the multi-domain interventions like finger and pointer, I think there is enough evidence to suggest exercise, not just for brain health, but it's been shown for, cardiovascular health. And we know that what's good for the heart is good for the brain too.
If I could have a short question, I mean, maybe not short, but so obviously the mechanism behind the benefit of exercise is quite complex, and it's very difficult to extract what would it be. One of the pieces that comes to mind right away is glucose, correct? I mean, so with exercise, you're definitely gonna bring up a glucose homeostasis and control glucose level much more accurately. And this is in part that every single exercise that could be an additional portion will also result in muscle buildup, correct? And obviously, this is an important, part of our body, controlling through insulin glucose level and stability of glucose level in the situation. Not to say that muscles themselves could secrete a lot of trophic factors and contribute to basically. So, have you ever tried to look at the muscle buildup due to exercise? So maybe in the situation cardiovascular versus muscle associated benefit or glucose associated benefit coming from the vessels. I think it would be a quite intriguing in context of basically a result with diabetes and insulin and pioglitazone having some effect on the cognitive function in those patients.
Yeah, I think that's definitely really important, especially also very relevant in the popularity of GLP-1 receptor agonist and kind of trying to tease apart the benefit of weight loss versus the possible detrimental effects of muscle loss. Unfortunately, we don't currently have measures of kind of muscle health or sarcopenia. I would love to have them, and I think in future studies that would be really important. What I didn't show here that is slightly relevant to that question is that the association between BMI and cognitive outcome, we found that it was being modified by how much baseline amyloid you have. So this obesity paradox, we see that in cognitively unimpaired individuals who have high amyloid, like this is from the A4 clinical trial, so very enriched with people with elevated amyloid burden. And in those individuals, people who were underweight or not underweight, sorry, normal, have normal or lower BMI, even though they start out having a higher cognitive score at baseline, across 4.5 years, they decline much faster than people who were overweight or obese. So this supports kind of what has been seen in observational studies is obese paradox kind of phenomenon, and I think really understanding muscle mass, bone mass, their protective effects, and what are the is it leptin, is it something else? I think those are important questions to answer.
So would you recommend then to go to training with muscles and weights, or just going on the treadmill and run miles at the same time?
I think I think there's evidence for both, and I do think that both is important in terms of which is more important. I think that's still kind of to be determined.
Mm-hmm. You're not going to pin her down, you are.
I think there's a question in the chat. Yes, not yet. Yeah, so with the study I showed, it was just baseline at study baseline. It was just a simple pedometer, so we only had steps per day. But in the future, with the actigraphy, we would at least be able to do kind of different intensity of exercise that would give us a finer measurement.
Yeah, we're, in Texas, we have patient populations, are not just the ones that you see in Boston, but we have a lot of younger patients who have developed vascular cognitive impairment. They're already developing cognitive impairment before they're building up amyloid. And so, we're recommending the same thing. Physical activity would be helpful to that too. So it's just interesting about the emphasis of the greatest benefit, being seen in older adults that are amyloid positive, kind of struck me like, well, the greatest benefit might actually be people who are at midlife with vascular risk factors already developing in early stages of cognitive impairment before the amyloid is building up. Regardless of the amyloid, because it's really tau that we're more worried about.
Yeah, I think we're, I think one thing to keep in mind is our measurements is kind of geared towards preclinical AD. So like tau accumulation is primarily, or early neocortical tau accumulation is seen in individuals who have amyloid. So it is, in one sense, not that surprising that we're catching this dynamic change in individuals who have amyloid. I think in terms of, I 100% agree that the greatest overall lifetime and societal benefit is really targeting earlier in midlife for prevention. I do know that prevention studies are hard to do. How do you maintain a a healthy habit for 10 years and measure the effects over 10 years. I think there are a lot of challenges to do a trial like that, and including the cost of a prevention trial that lasts that long. So really thinking about biomarker endpoints would be maybe one way to kind of get around that a little bit.
Okay, so I think I have a simple question. It's more about the data. So HABs. So this is like investigator only, or it's shareable resource? Like, can we access that data set?
Yeah, there is if you go to, I can put it in the chat. It is shareable, and you can apply or request online. It is in different kind of cycles or like data freezes. So I shared the HAB study link there, and there should be a like a researcher data request link.
Thank you.
Mhm.
Anyone else? Any questions? Yeah. Really, really wonderful work.
Thank you. Thanks so much for having me.
Thank you.
All right.
Okay.
Thanks.
Take care.
Nice
Have a great
meeting
day.
everyone. Bye.
Bye.